I've already been introduced. I'm Ben Wilson from Intel. I also co-chair the Accountable Care Community of Practice, which is a consortium of IT companies that are interested in developing best practices for building out the IT infrastructure for accountable care and patient-centered medical home. It includes Intel, HP, Dell, Microsoft, Cisco, GE, Siemens, Premier Health, many other organizations, and you can look for it at accountablecarecop.com if you're interested to learn more about it. So let's get right to our panel. What we're going to do today is I'm going to ask each of the panelists to give a brief introduction of themselves, 2 minutes. Then I'm going to ask them some questions for about 25 minutes, and we're going to have a discussion. And then we're going to take your questions for about 15 minutes, and then we have a video that we're going to wrap it up with as we transition to the next panel. So I'm going to introduce our panelists. So we have Neil Kalman, who is President and Chief Executive Officer for the Institute for the Family. Donald Fisher, Senior Vice President, Health Affairs and Chief Medical Officer at Highmark. Charles Saunders, who is President, Strategic Diversification at Aetna. And Roy Schoenberg, President and Chief Executive Officer at American Wealth Systems. So we have a great panel today, and we'll get right to their introductions. So why don't you start us off, please, Dr. Fisher?
Yeah, I'm Dr. Don Fisher, Senior Vice President of Health Affairs at Highmark Blue Cross Blue Shield, serve as the Chief Medical Officer. And in that role, really, I have responsibility for everything we do from a clinical standpoint, have accountability certainly to our accounts to make sure they're getting value out of the services that they're paying for. And important to recognize that most accounts, even down to even 200 employees now, are self-insured. So their expectation from a plan is that they are going to get value out of the administrative services, the care management services, and that we will somehow manage what's not happening out in the clinical environment with regard to coordination of care and disease management. A whole industry has been built up almost by default because of the fact that it's not happening out in the clinical environment. And it's for a variety of reasons. Not having the information, not having the skill sets, not having the decision support to find the people who have care gaps, who are falling through the cracks, not getting the services they need. So part of my team are people who are doing things like health coaching, who are doing wellness coaching, who are working at the work site with various accounts to improve care and focus on prevention. All of which should be happening really by design out in the provider space. So among the things we're doing to try to help facilitate that are pilots with patient-centered medical homes, beginning pilots with ACOs, to not only help design the care processes, but also the reimbursement that will make it worth their while to take over doing those functions. So I'll leave it at that for now.
Thank you. Dr. Schoenberg?
Sure. Thanks, Ben. First of all, it's great to be here again, and thank you for the opportunity. I'm Roy Schoenberg for American Well, and what we do is essentially build, implement, and turn on telehealth capabilities for a variety of different organizations that are at the center of delivering health in this country. We work with some of the large national payers, we work with regional blues, large delivery networks, national pharmacy chains, the VA and the government, and recently also with provider practices. Also, all for the purpose of really allowing them to start taking advantage of very scalable, robust telehealth solutions. And in that context, we work with the building blocks that these organizations work. We tie into their clinical systems and payment systems and eligibility systems with their analytics tools that identify what needs to be done with patients, with the stores of those pharmacies, the medical centers of the government and the VA and so on, in order really to allow telehealth not to become a gadget of like a video conferencing over the web, but rather a true tier, a true mechanism for care delivery. But the other thing that we've done, and I think is relevant for the discussion about ACO innovation, is that the other user of our system, for the very first time, unlike what traditional telemedicine was about, is really patients. These networks that we put in place are accessible to the end consumer of our business collectively here, which are patients. We bring the services to where the patients are. With that comes two value points. There is a social value point, which speaks to some of the things that the folks from government here talk about, really extending care, taking traditional care and projecting it into places where it is hard to find or whether it is inaccessible or inappropriate. And the second thing is really more the clinical effect of what happens when you take the healthcare system and extend it into people's homes. And when we talk about, and I'm sure we're going to talk about ACOs, when we talk about care coordination, or very, very importantly, when we talk about what an accountable provider needs to have, one of the building blocks is to be in touch with their patients. And that's where we serve. So this is where I come from.
Neil?
So my name is Neil Kalman. I'm a family physician, and I run an organization called the Institute for Family Health, which is a network of 30 federally qualified health centers in New York City and up the Hudson Valley in New York. And our centers are all level 3 primary care medical homes. We've been completely technologically enabled for the last 10 years. And are all in one large system, one large electronic health record system. About 20,000 of our patients now access our records through our electronic portal. We have about 100,000 patients overall, almost 1,000 employees, and we do mental health care, almost exclusively primary care, behavioral health care, and dental care in our centers, taking care of a mostly underserved population. I guess I'm here because we're trying to figure out whether we're the beneficiaries or the victims of all of the innovation that you just heard about. And I think as many providers are trying to find our way through the system to figure out what our role is in the evolving healthcare system. We've been innovators for our entire history of more than 30 years now. And try to be the first sort of out of the box to figure out what the next kind of move is to improve the health of the people we take care of. It's a very difficult population to care for. Many of them are homeless. You just heard about the plight of the undocumented. We have many undocumented patients in our midst. And I sort of say if we can fix things for the people that we take care of, we can fix things for all of America. I look forward to our discussion. I think there's lots of interesting implications in the works for healthcare providers, including some of the discussions I've had with some of my colleagues. And we're part of 5 different hospital systems. So as people think about integration of care and models and all of that stuff, think about the way healthcare is actually practiced in this country, which is in a very disintegrated fashion with people going all over the place, and what we're trying to do now in terms of organizing those systems and the reality of what that looks like on the ground. So, to you, sir.
Hello, my name is Dr. Charles Saunders. I head up strategic diversification for Aetna. That is Aetna's new and emerging businesses that are non-insurance oriented, primarily in healthcare IT and healthcare services, directed for providers and consumers. It's our goal to, through this, to address problems that we care about, such as access, affordability, quality, and convenience, with an array of services and capabilities for the industry that are transformational, that enable the change in healthcare that's occurring. Some examples of the businesses that we have under strategic diversification are accountable care solutions, active health management, a number of our HIE and HIT entities, Medicity, and a growing array of others.
Excellent. So as you can see, I have a great panel with some great knowledge to pass on. And what we're going to focus on today is not so much the policy behind accountable care, but we want to talk more about the nuts and bolts. What's it really going to take to conduct accountable care, to create an accountable care organization? So I thought the best way to start off, though, is to make sure we're talking about the same thing, that we're using the same terms and we understand it the same way. So I'm going to ask each of my panel members to talk about what is an ACO, how do you define it, and why now? Why do we have accountable care now rather than any other time? Chuck, why don't you start us off?
Well, we think about an accountable care organization more expansively than the Medicare fee-for-service definition that everybody's familiar with. You know, an accountable care organization is simply an organized delivery system where the provider has holistic responsibility for the patient across the care continuum and manages not only total cost but also quality of the patient experience, and is rewarded based on performance rather than units of services. Now, that's a lot. But the way that we look at it, it can be any patient population, not just Medicare fee-for-service, and it can be both an ACO and a PCMH model. So what we've been doing is creating all-payer solutions that cut across Medicare, Medicaid, commercial population employees, and then uniquely enabling private label health plans in the market, so providers can take their ACO product directly to the employers. Now, that's what we think of as the ACO. Now, what has caused that and why now has really been, the tipping point for that has really been healthcare reform and the ERA funding, stimulus funding. But it comes on the heels of some very successful demonstration projects with the likes of the historical integrated, clinically integrated systems like Kaiser, Geisinger, and others, the new ACO demonstrations like Curlian, for example, that have shown good results with now the emerging maturation of the enabling technologies through ERA and the weighing in of the commercial entities, whether it's payers or employers or others, to help stimulate that transformation with their own commercial lives.
Neil?
Well, I think of accountable care as kind of a calling, and it calls out for us, I think, the major failures in our healthcare system. Terrible outcomes, tremendous costs, and a lack of focus on population health. So here we have a model, and I think it's kind of the first one out of the box to say we need to kind of change the vision for where we're going. So for me as a primary care provider, it says time for folks to look at primary care, the model of primary care, what it means for people to have a medical home, and what role primary care providers can have in connecting with patients, because I think it's in that interaction that we actually have some hope of changing the way healthcare is delivered. The mystery, I think, is how that will evolve in terms of relationships with specifically high-tech specialists and with hospitals. I think it's enormously complex. I think until the majority of people are cared for in these kinds of different financing models, that we're actually not going to be able to sort of change overutilization. As a primary care doc, I've been trying to fight the overutilization of high-tech specialties and emergency rooms and hospitals for years. And we're up against a fee-for-service system. So if ACOs are anything, it's an unraveling of that reimbursement system to try to put incentives in place to do things in a completely opposite direction from the way they've been done before. And I think a way to establish new relationships in healthcare. I know we've been talking to lots of new people that have never wanted to talk to us before, namely hospitals all over New York City. So I think that'll be an interesting evolution.
Right. Well, I don't want to repeat everything that was said. I think these are, the nuts and bolts of ACOs. But I think fundamentally, at least for us, and gladly we're in the technology business, not so much the healthcare delivery business, it's a model of efficiency. I mean, it's the recognition, on one hand, that most of the organizations outside of the actual care providers have great difficulty in directing efficient healthcare. And at the end of the day, patients are different, patient mixes are different, geographies are different. So there is a recognition in the fact that efficiencies and better utilities can actually be generated primarily by the discretion of the providers. With that comes a couple of different categories of added efficiency. Some of these are administrative, some of these are actually clinical, and some of these have to do with management of the patients, which used to be care management, disease management, and so on. In those areas, I think, at least in what we see, there are places where physicians and provider groups are much, much better in creating efficiencies, the clinical thinking and cross-utilization of skill sets within an ACO. In other areas, in terms of patient management and administrative areas, I think the ACO is ahead of its time, so to speak, in terms of really empowering these groups to do it and generate those efficiencies. But overall, it's a model of efficiencies that places physicians somewhat in the driver's seat to understand where these efficiencies can be generated.
I think it's probably helpful reemphasizing why we're heading in this direction, what the root problems are. By and large, quality of care in this country is very poor. People and physicians in general don't recognize, because they haven't measured by and large what their quality is. There's a lack of registries to be able to really measure what's going on in a surgical practice, for instance. And when we throw out this term accountable care organizations, I think it's important to understand too, there are really very few places that have done this where there really is a successful example. I was in the presentation by Marshfield Clinic this morning, and I felt like I was in Disneyland. It's like, what world is this? There is nothing like that in our backyard. And then you start thinking, well, why hasn't this spread? I mean, they've done something really, really remarkable, and there are pockets in the country where that's happened. But by and large, there's a complete lack of care coordination. People jump from place to place to place without anyone having full information at the point of care. Our incentives drive volume for each of the players without any accountability beyond that episode of care. So you get somebody out of your hospital, and whether they come back or not to the ER, to somebody else's hospital, you don't know, you're not aware, you're not accountable for it. So I like to think of the way hospitals are built, the construction dilemma that is a hospital, where every time some new feature is desired, you add on a wing, you add on a floor, you change a floor. There is no master plan. And that's the way we are with regard to healthcare delivery. It has happened bit by bit, piece by piece over time. We add a new fee-for-service, we add a new CPT code, but nobody really starts from scratch and says, let's design this to meet what the patient's needs are. So we throw these terms around: patient-centeredness, evidence-based care, and I've talked to physicians who say, we're patient-centered, we're evidence-based, but in fact, they really aren't. And I think the comment that was made about, what does the patient want as far as time saving with seeing a doctor, there are lots of tools out there that would not only be advantageous for the patient with regard to use of their time, but also for the employer. The employer doesn't want the mother to take off work for the afternoon, or the father to go pick up their adolescent who has acne from school, take them to the dermatologist, wait, be seen for 2 minutes and get a script that they then have to take to a pharmacy somewhere. This could all be done much more efficiently, but we need a reimbursement model that makes it worth the while to be able to have that happen. And I'm going to say it's not a fee-for-service system that's going to pay you for that electronic visit. It's some sort of a capitation arrangement with a quality bonus, with an episode-based bundled payment, a methodology that has to be much different than it is now, that rewards a team to manage that care. So that's touching on a lot of different issues.
Excellent. So since we all got together on a conference call to prepare for this, the final ACO regs came out from CMS. And so I wanted to put our panel on the spot a little bit and ask them to give us their personal response to the new regs, as well as their organization's response, or any of your key stakeholders or constituents' responses to the new regs. And Neil, can I start with you? Is that fine?
Yeah, well, for us, the new regs were a radical change. In the initial proposed regulations, federally qualified health centers weren't allowed to participate in ACOs, and they weren't allowed to, well, they were allowed to participate, but they weren't allowed to have patients attributed, and they weren't allowed to lead ACOs. So naturally, our constituency screamed loud, and CMS listened. And so we really haven't had a chance to figure out what the new regs really mean. I think that the idea of primary care providers banding together to form an ACO is actually a really good one. And the question will be whether or not people can actually play together in the sandbox well enough to become a powerful enough force. You know, clearly there's huge group practices that can do this, but whether or not independent groups can get together and actually work together to form an accountable care organization that's led by people in primary care, I think will be sort of an interesting development and one that we've begun to explore. The biggest thing that's changed, not just with the new regs, but with the whole discussion of ACOs, has actually been the number of calls I've gotten from people who literally had no interest in primary care. One of the big hospital execs in New York who I spoke with a couple of years ago said, you know, our medical center, you don't get it, our medical center is not the provider to the community. It's the provider to the world. And I thought, well, that sort of says it all. If you're in New York City and you build one of these big institutions, that sits in one of the poorest neighborhoods in New York, and you don't see yourself as a provider to that community, what does that mean about accountable care, you know, in that geographic area? And not long after the ACO proposed regs came out, I got a phone call from that CEO who said, we heard that you run one of the premier primary care organizations in New York City, and I'm wondering if you'd come and talk to us. And I thought, wow, this is the world really is changing. And the discussion started out about care transitions, and it led quickly to what do we do to sort of fix the ambulatory care that we run to look more like a primary care medical home, and then quickly to what do you think primary care physicians can actually do to help reduce the costs of care and to reduce some of the use of technology and to reduce the use of the emergency room. And after I got done sort of trying to figure out what this was all about, you know, it's clear that this is being driven by a completely new calling that's been put out on the street, and that is things are not going to be the same a few years from now as they are now. And I think it's going to drive new relationships. So for us, we've been trying to figure out what those new relationships mean and what they mean for our patients, you know, what they mean for how care is going to end up being organized in the communities that we serve.
Great. Chuck?
Yeah, I don't want to speak for Aetna officially yet because they haven't come out with their analysis and their position on it, but I can just make a personal comment having read the regulations and participated in conversations with health systems across the country, and I would say that it's generally a favorable impression. I would say that CMS has listened, and for that we're gratified. Most of the objections have been dealt with. There's still the issue about the baseline for health systems that measures against their own performance rather than a community, say, market basket or benchmark, which penalizes the efficient systems. But having said that, the reaction has generally been favorable, and I wanted to put this in context a little bit. When the Medicare fee-for-service ACO regs came out a while back, you know, they felt like a lead balloon. You know, essentially nobody was interested in doing them. And despite that, the train has started leaving the station with ACOs led primarily by the commercial community and other programs. So in our own experience, and just in the last 18 months, we've done over 55 PCMHs. We are in the process of implementing more than 20 IDN-centric ACOs, and we've got a pipeline of 120 health systems in various stages. And none of these involve Medicare fee-for-service. So they involve Medicare Advantage, Medicaid, commercial populations, private label plans, et cetera. So now with the improvement of the ACO regulations, this is, I think, another log on the fire, another tipping point that's going to occur that's going to, I think, stimulate and accelerate adoption. And we've already begun to hear from health systems that we've been involved with saying that, okay, now we want to start talking about fee-for-service. So I'm pretty hopeful, but it's not an official position by Aetna.
Right.
Sure, I'll be brief. I think we also see it as very favorable. In our world, the ACO regulations came out and they name specifically 3 technologies with which they're going to certify ACOs. They talk about EHRs, which is no surprise to anybody. They talk about telehealth, and they talk about home monitoring. That's it. There's the only 3 technologies named in the ACO regulations, which, since we're doing one and most of the other of the 3, that makes us very happy. What the implications are that we actually see from our clients, mostly from our payer clients, is that when they are negotiating their ACO contracts with a variety of either group practices or delivery networks, they are beginning to incorporate some of the telehealth capabilities as part of what they deliver with the contract. Essentially, they're saying, if you're an organization, you're going to assume risk for your patients. We're not only giving you a financial structure, we're also going to give you the tools that are necessary for you to be accountable for your patient care. Essentially, you need to be much closer to your patients. You need to be much more efficient in the way that you're interacting with them. You need to increase their compliance for the guidance that you give to them. We will equip you with the tools to do that much more effectively. So on both sides, this is actually, as far as we're concerned, a very, very favorable outcome.
Yeah, I would agree. They listened to the stakeholders, and there was lots of stakeholder input into those final regs. But they're very complicated. And I can tell you that, providers in the community, even those that are of some size, are confused. They're not sure, will they qualify? They're not sure where to start. And I think part of this has to do with the very poor penetrance still of electronic health records, of health IT, of decision support, of things like registries. There are providers of some size who've had experience, who are ready to go. But that's not the bulk of providers in the country. And I think, too, CMS has been very reticent to be too demanding, to push too hard, to push the envelope. They've backed off on some of the meaningful use rules. There've been pushback from providers, we just can't be expected to be there in this timeline. It's like, no, there have been early adopters who've been heading this direction for a decade. Why is it we're still tolerating that people, the providers will not move in this direction? So I think to some extent, yes, they're forging new territory, but they're also being very reticent. And I think it's very much in the private payer space where we can accelerate this movement and do some pilots that may push things faster. I can tell you we as Highmark have taken a bold step of actually deciding to become an integrated delivery network. And this has made national news with the fact that we had the former AHRF, which was the biggest health bankruptcy in the country's history back in the late 90s, in its new iteration as the West Penn Allegheny Health System was about to go bankrupt again, and we've decided, no, we do need this provider entity in the community. They will become affiliated with us. We will, in essence, buy them and make them integrated so that we can really look for the first time at how can we really integrate and align the incentives among the members, the accounts, the providers, and the plan to get something that is accountable in a broader space. So I think you may see more of this sort of model happening as we move forward, that truly IDNs may provide a tool for accountability.
I want to build on that point, Don. I want to come right back to you with a question. We see a lot of different models of accountable care proliferating, and you just talked about the IDN model, and you as a payer are helping to support that. What do you think are the models that will be most successful in terms of accountable care and ACOs going forward?
Well, I think it's probably easiest to start with a patient-centered medical home and be able to look at accountability on a scale where you're responsible for a certain level of population health. Unless you engage the specialists in the hospitals in a broader accountable model, you can't really be responsible for episodes of acute care. That becomes much more difficult. Or say an episode of somebody fracturing their hip or somebody needing coronary artery bypass grafting. But there are things you can be accountable for in the patient-centered medical home space. And I think the scale of that is something that is easier to start with, and it's a form of accountability. But it's not the broad accountability that you'd have in an IDN where you'd be responsible ultimately for the entire population health. And there are models like this where, I mean, if you look at a risk-based capitation model, that's essentially what Medicare Advantage plans are now. CMS is paying a fee to a plan to manage that whole episode of care. But it's the health plans who have that accountability and the tools, the information, the risk ID and strat models to be able to manage that. Ultimately, it needs to be in the provider space. And I would argue, if you look at other countries, Clalit Health System in Israel is a great example of a risk-based capitation model where everybody's in. All the providers are part of that, the pharmacies are part of it, and they take a fee from the federal government collected from taxes, and those individuals in Israel choose one of 4 systems, one of 4 plans. And it's been modeled there, and they do a great job of it. And in fact, their quality is significantly better than we see in the United States, and they spend less money doing it.
Absolutely. Yeah, I just visited with someone from the Maccabi Health Plan, who's one of those health plans, and they're able, the patients as well as the providers are able to access all the patient's data on an iPhone or BlackBerry anytime, anywhere. It's pretty amazing.
And no matter where you are in that country, if you're in that system, you can go to an ER, you can go to an outpatient facility, all your records are there. You could have a CT scan in the north one day and have an ER visit in the south the next day, and they have full access to your information at the point of care.
You know, it's funny when you think about what a model like that would look like in a big city where, you know, we have a history of these huge institutions competing with each other. And there was just an article that came out on how in the last year the marketing budgets of the big academic medical centers in New York have just gone through the roof. People are hiring these huge, you know, Madison Avenue marketing firms to sort of market, you know, their high-tech services. I mean, nobody's marketing their primary care, nobody's marketing their preventive health, nobody's marketing their community programs, and nobody's marketing sort of the ways in which they reach out to consumers or anything. They're marketing all of their high-tech services. The ads all have pictures of machines and operating rooms and emergency rooms and whatever. I just wonder if anybody thinks that we can actually turn that culture around. You know, that it's so deeply embedded in the way healthcare is in this country and the way consumers think about it, the way providers have profited from it all along. It just, you know, it seems like the ACOs are sort of knocking at the door of a changed model, but at least living where I live, it's really hard to imagine a model that's really tremendously different from that emerging. And I know you said that's happened in other parts of the country, but hard to imagine it in either where I went to school in Chicago or where I've been for the last 30 years.
Chuck, it seems like Aetna is building out a strategy around accountable care more broadly. You must be imagining it in some way.
Well, we're more than imagining it. The question that you asked was, you know, what are the most successful models? And we've been doing a lot of different models, and so we're gaining some experience. We've done commercial, Medicare, Medicaid, employee populations, and then private label plans for the local markets. And I would say that an answer in 2 areas. One is in the medical home, and the other is in the IDN-centric ACOs. So in the medical home, the ones that are most effective are the ones that deal with the high-cost populations, you know, Medicare and Medicaid, but also that have a cohesive group with the infrastructure that they need to manage costs, which means care management and technology, and then the right financial incentives. And we've seen in some of our best models, we've seen about a 42% reduction in the cost of care with those with Medicare Advantage. On the IDN side, I would say it's a little different. That those The ones where we've seen the largest projected drop from an actuarial standpoint, and I say projected because nobody's had enough multi-year experience with these other than, say, Carillion, which is one that we work with that does have a track record, is about a 25% reduction in the cost of care on an actuarial basis. And these are the ones that are creating private label plans and going directly to market because they have the most to gain and that they have the efficiencies derived by cutting out the middlemen and taking more of the value chain. And it's a powerful incentive for them to get their prices down. And so it's a combination of both a drop in utilization, a drop in in some cases their fixed costs, but a drop in their unit prices too, all combined to get literally about 10% below market, for those areas. But these delivery systems are generally very clinically integrated, have invested a lot in infrastructure and care management capabilities, have both HIT and HIE, which play a critical role in the solution. In fact, it's hard to imagine how you get there without a combination of HIT, HIE, and the clinical analytics that sit on top of that and point out the gaps in care and do that in real time and allow you to manage the patient. So I like those two models. They seem to be getting the most traction in producing the best results so far.
Roy, I want to ask you a question taken in a slightly different direction, if you don't mind. Chuck was just talking about HIE, EMR, analytics are sort of required technologies for accountable care. I'd like for you to start talking about what do you see as some of the technologies, the IT infrastructure that's required for accountable care?
Well, I think maybe taking it from the example you gave on Clalit, I had the privilege of being a Clalit member many years ago. So one of the other components they have is they own the hospitals too, not just the physician practices and labs and pharmacies. They actually own the hospitals, which makes it really a very cohesive system. But maybe to the question that you just raised, when we think about coordination of care within an ACO, so the truth is, we had the killer application for coordination of care in front of us for so many years. It's called the telephone. When did a physician, or how often did you see your physician calling another physician and another physician to coordinate your care with them? You don't get me wrong, I want to sell high-tech technology to everybody, but the phone is there. It's been there for a while. I think one of the things that are a little bit still complicated, and you're absolutely right that the ACO regulations are complex, is that it's really unclear where the reimbursement comes in for the physician, even within the ACO, to actually constantly talk to another physician. How do you even charge for the time where there's no patient around and this physician is calling another physician to coordinate the care around that patient? And that is still murky waters, and I think that until that changes, we're gonna still be in trouble, even with the greatest technologies. But the one thing that may actually make some change there is that when we implement tools that allow physicians to care for patients, harnessing together the know-how about what needs to be done for that patient, know-how that usually lives elsewhere outside of that exam room, and not sending it as a letter to that physician, or by the way, also as a letter to that patient, you need to do this screening test or whatever it is, but finding a way through technology to inject it at the right place at the right time into the hands of the person that has the ability to actually change the health behavior of the patient, which usually is the physician, because that's right or wrong, that's the person that patients actually listen to. That is going to be a dramatic effect on clinical efficiency. And I think Aetna is doing a lot of this with Active Health, which has the know-how, and admittedly United is doing it with eSync and others. But the technology is going to play a role not only creating administrative efficiency, but bringing the one little piece of information that actually would move the needle on the care of that patient and plug it into the scene of the crime at the right time. I think that's going to make a huge difference in terms of clinical efficiency.
And I would say it also needs to be patient-centered, so it needs to be to the patient at the right time. So, I saw an ad last night when I watched the Steelers-Ravens game, which I was in mourning after, but there was an ad for a car. The technology would be that you would actually be monitoring the car in real time. Someone would be doing it. And you'd have a mobile app that would tell you when your car actually was having a problem before it started to fall apart. So, why not the same with individuals? If it's really patient-centered, they would get that care gap. They would get that in a way that was really meeting them where they wanted to be, coincident with their physician, so that, you could coordinate that care and make both accountable. And there's been a lot of work, I'm sure, Chuck seeing the same thing with member-driven benefits that reward the member for taking better care and closing care gaps and, getting the preventive care. We really have to align the member in this as well, or the patient in this, as well as the physician accountability.
But it's very politically incorrect to say that we want to make the patient accountable.
Yeah.
Right?
Well,
That
CMS doesn't want to do that,
Accountable
but I
Care
can tell you
Organization has
the
nothing to do
accounts
with the
want us
patient.
to do that.
And the
to
accountants.
Yeah, and yeah.
Go ahead, Neil. And
I
then
guess
we'll get to you,
two
Chuck.
things. From a systems point of view, I wonder whether it's not the systems that have been sort of functioning with this in mind for a long time that aren't going to be the ones that are successful, and whether or not, the whole country can move in this direction. And from a provider point of view, the providers for whom accountable care is a natural are the people who've been in primary care medical homes long before that term became popular, who've been doing this stuff all along. And the question about whether or not providers who haven't functioned like that will morph to function like that is of interest to me. Plus, I think, the thing about fee-for-service is it's very concrete. You do something, you do a scope, you do a visit, you do something, and you know what the dollars are that are being driven by that visit right away. And now we're moving to a much more global sort of concept, and you're saying, do this now, communicate, spend all of this time, do all of these things, because down the road, this patient will do better, cost less. And there's a belief system involved in that I'm not sure everybody yet believes in, that actually costs will be reduced. And there's a culture change in there that I think we've underestimated. I think we've underestimated how difficult it's going to be for people to sort of switch from how they are. Having said that, I mean, these are the moves we have to make. There's no question that the call out to accountable care is exactly what we need to do. I just think that we shouldn't overestimate how the impact that it will have. I think there'll be early movers. I think there'll be places with great results. But I think when you look back at those places, there'll be places that have been sort of thinking about and moving in that direction beforehand. And the places that are going to be harder to deal with are going to need all of the innovations that we heard about. They're going to need these special programs on care transitions. They're going to need, the full spectrum, the bundle payments, the patient-centered medical homes. They're going to need all of these things to kind of move us in the right direction. And I guess we should call them all accountable care, because they really all are moving towards that model.
Yeah, I'm definitely trying to use that term more broadly.
Yeah.
Absolutely. Chuck, talk to us a little bit about what you see as the IT tools that are required and what you see in the market today, and then what you don't see. What do we need to build?
Yeah, so we've we've been spending a lot of money lately just buying assets and capabilities because we see the world shifting, and the technologies that most health plans and population-based managers have are claims-based and retrospective. And I think that in our own experience with Active Health, we've had good results with that. I mean, we generally can show an $8 to $10 reduction in PMPM with care alerts and care engine and things like that. But it's retrospective, so that you send the message to the physician after the fact and tell him that he killed somebody last month, and that's not helpful in changing the course and the care. So what you need in the new environment of accountability, you actually need to be able to make a difference in real time, within the visit. So you need a couple things. Number one, you need to have health information exchange capability so that you can actually get access to clinical information. You need to have a marriage of clinical and claim data, both of those types of data, not just claims data. You need to have some kind of semantic glue that normalizes that information. So clinical information, even though a lot of it is structured, most of it's still unstructured. It's text-based information, discharge summaries, it's dirty HL7 messages, et cetera. So you need to semantically normalize all of that information so you have both claim and clinical data in machine-readable format. Then you can fire rules against those to create a holistic picture of the patient, to populate a personal health care record, populate your disease registries, et cetera. And then you need to have a platform for care coordination and workflow management, and that needs to integrate back into the CPOE systems and others, the decision-making systems. Now, I've described a lot of stuff there. The last thing that you need to do is you need to have some kind of health plan services technology, TPA services, call it what you will. There's underwriting, there's product design, there's distribution, there's membership and network management, there's analytics, reporting, things like that. That's a lot of stuff, but all of that stuff is emerging now in the marketplace, and it's available in a variety of different hands and services. So what we're seeing is the need to knit that together and implement it, and it's going to be a long journey to get there. There are a lot of pieces that are just newer than new and have to be put together, but it's a complete change. It's not enough to have an EMR. It's not enough to have a claims-based care engine to tell you retrospectively by mail, what you should be doing in the next hour. So,
great.
Well,
all right.
nobody can.
So in a couple of minutes, I'm going to turn to you and ask you for your questions. So please start to gather those, and whoever has the microphones, please make yourself known. And if you have she's in the back, and if you have a question, go ahead and start raising your hands now as we're talking so that we can keep things moving along. We've had a good discussion so far. So my final question to the panel is, you've alluded to this, most of you, about the empowerment of the patient, empowerment of the consumer, and all this, and how important that is. So tell me about that and a little bit more, and also how you think that can happen. And Don, do you want to start?
Well, I think one thing it's tied to IT is we need transparency tools for consumers. So especially as we move into 2014, and we're going to have a big shift in the number of people who buy insurance as an individual product. They need tools when they're on the exchange to be able to decide, what plan they're going to choose, what providers are in the network. And as people are making decisions about where to go, am I going to go to orthopedist A or orthopedist B for my hip? They want to know and need to know. And that would be defined as who has, what's the percent of redos? What's the percent of returning to work within a week? What's the functional status afterwards? And what's the cost? What's the difference in cost if I go here versus there? And there's a whole concept being pushed of reference-based pricing. Rather than a co-insurance or a co-pay, we'll give you, your benefit might be that you have $15,000 to be able to use for a hip replacement. And guess what? The range for that is $10,000 to $25,000. If you want to spend more than $15,000, you can pay it out of pocket. So a drive to try to make people have more information in a very patient-centered way about making their choices. So I think that really needs to be linked in to the accountable care organization, that they're willing to make transparent all those registry outcomes, all the cost information, so people can make wise choices.
I think the simple thing, and I agree with Chuck that you need, and with you have to have transparency, you have to have the right data, it has to be clean, it has to be understandable, it has to be acted upon, and everything else. But at the end of the day, fundamentally, patients are not in the healthcare system. They're outside of the healthcare system. They come there when they are in trouble, and then they get treated, and then they go home. But they're far from out of harm's way. We know that when we operate on patients in the hospital and then we discharge them as quickly as possible, because that's what we're told we need to do, they go home and carry many of their medical issues, and bad things happen, and there's nobody there. We have to understand that if we want to create a healthcare system that is going to be, on one hand, accountable, it needs to walk with the patient through their healthcare issues throughout the spectrum of those issues. Most of it happens when they're not in front of us. We need to take, and we can use technology, and I, of course, represent one part of it, but we can use technology to take the traditional healthcare system, make it better as much as we can with EMR, EHRs, analytics, and everything else, but extend its coverage to include the periphery, which is really where our clients are. And whether we use it with telecommunication, or whether we use it with transparency tools, or whether we use it with static information that patients can access to understand the choices, these are all components of the same thing. Healthcare has to go home. That's where our clients are. And once we start doing it, there is an ocean of opportunity that opens up, not only for efficiencies, but actually also to make our patients better and feel better. So,
Jeff?
Yeah, I think we agree, and we agree that the patient engagement is the other half of the successful solution for accountable care and reduced cost of care and greater quality. And we have a vision for that is a comprehensive end-to-end experience measured in terms of convenience as much as it is in terms of we normally think about as quality. And it starts as both behavioral and it's transactional. Behavioral driven by the incentives and the benefit plan design in selecting the plan, the providers, the low-cost network or the ACO tier or whatever it is, but it's also transactional, starting with engagement at the point where service is needed, symptom processing, searching for and finding a physician, guided by transparency tools and other factors that are important to them, so they're making the choices right for them. Being able to find the provider closest to you when you've got an acute need based on what your symptoms are. Be able to book an online appointment immediately, directly. Being able to then follow through after the visit and go and immediately see your personal health care record with the results. Get guidance and other types of things as a result of that. And we also need to meet the patient where they are. So I think that there was a comment that I heard about why can't we get patients to fill out our data for us, as providers. And I would think that we should actually be surrounding them with what they need to make their lives easier so that they will be encouraged to engage in a compelling way. So that means things like mobile devices, embed these in social networking experiences so they're driven with the strength and encouragement of their peers, so that they can actually share their experiences that creates kind of viral adoption. So those are the kinds of things that we're thinking of. So you're going to see a lot of mobile devices and other types of tools, et cetera, that allow people to interact in a more convenient manner with the healthcare system.
Very interesting. Neil?
Well, as a primary care provider, I think one of the most useful things an electronic health record does is it gives people access to their own information. So we've been focused on that from the very beginning. I think patient portals do one thing. I think people need some consolidator of their health information because they have health information everywhere. And until we can figure out how we can get it together and then give it to people in a way that's actually meaningful to them, I think it's going to be tough. One of the things we did was we linked up our patient portal with National Library of Medicine Medline Plus database. Very interesting thing that happens. Somebody goes into their patient portal now, and every term in it, every diagnosis, every lab test, every medication is hyperlinked to the National Library of Medicine, and which is available in over 20 languages. And so we pick up the field in our electronic health record where the patient puts down their preferred language, and it brings up the National Library of Medicine data in their preferred language. And so one of the things that we found through this, and I think it's been a lesson to us, is we've done some usability testing with this. People go into their record, they click on a hyperlink, and they're now in Medline Plus, and they don't go back to their medical record. And at the end, when we interview them, they say, "Oh my God, I never knew there was so much incredible information available to me." And they just get lost in Medline Plus. They just dive deeper and deeper into these issues that they have. And people want, accessible health information. I mean, I think the hunger for that is something that providers underestimate. And we have to figure out all kinds of ways of giving people access to that information. And using mobile technology, I think, is going to be the key. Almost every one of our patients, no matter how poor, has a cell phone. And most of them are web-enabled, and people walk around. That is their access to the world. It's been such a democratizing force to see people, who really have very little in the world, but are totally connected to all of this information that they've never had accessible before, And I think we need to really figure out how to use that in ways that take advantage of all the social media and all of the other things that people are using commonly to try to link them up with their health providers and with their health information.
Excellent. All right, so now we'll go to your questions. Do we have a question back here?
Yeah, hi. Chris Tucker from Healthline. A couple questions about the ACO regs that the panel was asked about their reactions to them, but could someone take a crack at summarizing what they were? I've heard about EMR getting
All
relaxed.
6,000 pages.
Like, well, no, just at the high level. The EMR requirements, I believe, now has been relaxed. Some of the downsides are taken away. Maybe there are changes in anti-competitive or antitrust. And also have the employers, like the employer groups or AHIP, taken a stand or given a reaction. I'd be curious if someone could summarize what these changes really include.
Does anyone want to take a crack at that?
I'll start with the employers. I mean, employers really, this is not relevant to them. This is all about CMS. This is all about Medicare. At the same time, their expectation of plans is that we will be doing something similarly and that we'll move it faster, that they'll get a return tomorrow. So, I mean, the employer expectations are much different than, I think, than CMS. But really, the regs are so extensive, it'd be very hard to summarize more than we've done
If you
now.
do a web search, you'll find all kinds of consulting groups that have done their 10 and 15 and 20 page summaries of the ACO regs. I would recommend that. That's probably the best way to get a summary of what they are. I think they're way too complex for us to summarize in 6 minutes and 3 seconds.
Yeah, and if you want to find me on LinkedIn, I'll send you a summary that we have if anybody wants it. Who has the microphone? Who's next? Question back here?
Yeah, the question I had was following up on Don's comments about transparency. How do you see providers opting in to provide transparency on their pricing and their quality of service? Because they're not doing it now. So what's going to cause them to do it? And second question I'd ask them is who should be providing the information in the portal? I mean, I hear a lot of the healthcare plan people doing it, but a lot of times consumers don't trust them. So should be the agency? I mean, is it going to be the health plan people? Who do you think is going to be doing it?
Who's doing the transparency?
Well, who's going to? Okay, first of all, how do you get the providers to opt in, provide their pricing, and provide their quality care, and rate themselves or be rated, right? And how do you do that? And the second, because that would drive down costs, and that would drive down, and that's maybe something they don't want to do. And then the second thing is, if this is going to happen, who's going to provide this portal and this information in a non-biased way?
Yeah. Okay. Well, right now it's happening on behalf of a variety of. There are some vendors out there who are doing this, who are measuring. CMS is doing it, say Hospital Compare. If you look at that website, you can look at information about hospitals, providers, and many health plans are doing it. But I would argue that most of what is out there now is pretty rudimentary. So you'll have things that are graded on the basis of $sign versus $3 sort of like as a GAT, which is the expensive restaurant, which isn't. But nothing that's real specific, or there'll be ranges. I believe the health plans will drive this, but ultimately in the accountable care organization world, the providers will see it to be advantageous. If they can show in a more sophisticated way what their quality indicators are and what their cost efficiency is, they will have people coming to them preferentially. It'll be a strategic advantage. So, I think ultimately that's where it is. Right now we're at the stage where, physicians by and large are saying, you can't put that out there. I don't trust your data. You can't put that out there. Well, it has to be out there now because accounts are going to walk unless we provide information to their members. So, it's a big trade-off, but I think we're heading into that territory.
And just briefly, because I want to go to another question. Go ahead.
Oh, I was just going to say that there are a lot of different, to Don's points, there are a lot of different places that are doing it. So you're getting companies that are, commercial companies are providing reference-based pricing, that are providing more specific pricing for plan sponsors, using that plan sponsors' adjudicated claims. Aetna does it for its own members. In fact, we actually pre-adjudicate the claim in real time when somebody wants a service and give them the precise, down to the penny, what it will cost. But what we do for non-Aetna members, non-Aetna providers, is simply provide reference-based pricing for that local geography. But you're right that some large provider groups refuse to allow that information out there. But I think that's going to change as more and more plan sponsors, groups like PBGH and others, start to demand that if they want to be included in network.
Just a quick word. I think the price stuff's going to be easier than the quality stuff. I will tell you that if if all of the quality data on surgical outcomes and hip replacements and other things starts to get released, my patients won't get any care. Because the high-risk patients, people have, it's very easy for providers. There's study after study that's shown how easy it is for providers to manipulate the patients they care for, and what profound impact that has on their outcomes. And so you can take low-risk patients, you can operate on them, you can, you can decide what kinds of folks you're going to take care of. And what we really have to worry about is to make sure that the kind of thing that we're calling transparency ends up getting risk adjusted in somehow, and there's not really good mechanisms yet for that to happen. So just be cautious. I'm one of the few people who says, I still want to see the process measures. I still want to see I still want to see the measures that show that people are doing all of the process stuff right, because some of their outcomes are going to be out of their control and are going to be a result of the patients they choose to take care of.
Let's do one more question. I'm sorry, Roy.
Ginny Lenahan, Care First, and I really appreciated your comment, Dr. Schoenberg, about the political incorrectness of holding patient accountable for their own health. But at the same time, when Dr. Kalman was talking about a patient being given access to medical information, they couldn't get enough of it. There's a hunger out there for patients to be able to learn more about their own condition and what they can do to support their own health. So while it's politically incorrect to hold a patient accountable, I don't see any improvement in this country's healthcare until somebody somewhere figures out how to make that happen. And it seems to me if we can make MDs, and I've worked in healthcare long enough to remember the term minor deity being applied to MDs, being willing to actually alter their behavior because they're incented to it, because of peer pressure, and they want to look good, they're competitive. I can't believe that people, just regular old patients, can't be motivated in similar ways, whether it's money or looking good or whatever it takes. But I don't think we're paying enough attention to trying to avoid people getting sick in the first place. We've got so much focus on chronic conditions.
I'm sorry, we're running out of time, so I want to make sure we get an answer to your question. Thank you so much. Go ahead, Roy. Quentin.
When I say politically incorrect, it's not because I think it's wrong. It's a shame that it's politically incorrect. And I think the one thing that actually ties a lot of the discussion here is if we made patients accountable, probably we'll do it by money because that's what motivates most of us at the end of the day, kind of in a way. You're going to get patients acting as consumers because they're going to ask, do I need to spend that kind of money or not? When they do that, they're going to ask for, I need to base my information, my decision on good quality information. Interestingly enough, to the question about rating that comes in here, so there is the Michelin guide with food critics that tell you what restaurant is good, and then there's the Zagat, which is popular rating of restaurants, where the masses tell you this was a great experience. You may want to go there. We don't have to, and that's another second politically incorrect statement that I'm making today, and for the physicians here, we don't have to ask physicians for permission to say what patients think about the service that they've delivered. This has nothing to do with case mix. This has nothing to do with specific type of procedures that they do. The masses out there, when I want to find a good physician, I ask the people I know, not an encyclopedia. If we took the approach of saying, let's give patients, A, the accountability, B, the risk to a degree, and C, the tools to make decisions, we're going to move the needle on healthcare. Unfortunately, ACOs are not structured to do that.
Well, Don, I'm going to give you, unfortunately, the final word. We've run out of time. It's been such a great panel, but go ahead.
You're going to give me the final word?
Yeah, unless you want to pass it on to someone else.
I agree with everything that was just said.
Okay.
Well, I just say one thing. One of the things that providers criticize about the ACO legislation is the fact that the patients have free choice and can move in and out of ACOs. And I find that so amusing that providers, in this day and age, when you think about it, what are they asking for? To lock patients into our system. Why? Because we haven't earned the ability to keep them in our systems through loyalty, through education, and through other things. So the provider community comes out and they say, lock them into our system so we can truly be accountable for them. But in fact, the way to be truly accountable for them and to them is to be accountable to them. And I think that freedom. I hope CMS won't listen to that piece of feedback that they constantly get, because I think they're on the right track with what they've done.
Okay, well, thank you so much. I want to thank our panel, Dr. Fisher, Dr. Schoenberg, Dr. Kallman, and Dr. Saunders. Thank you so much, and thank you all for your time today.
Thank you.
Thank you, Dan.